a lot of workshops which we are planning to hold closer to the place where we are working. So it's going to be on Thursday between 2 to 5. And the first program is being done on 10th of Feb. So keep your Thursdays busy with IAP Delhi, whether it is a monthly meeting which is third Thursday or it is a workshop which will be held in association with any of the branches. On 10th Feb, we are doing with North Delhi, and we are doing autism and developmental screening along with Dr. Shambhavi Seth and Dr. Ashish Sani. So keep your days fixed for us so that we have interactive program more. As soon as these COVID, the restrictions go away, we like to do more and more physical. Workshops are always better physical. So with Dr. Deepak, the president of IAP Delhi 2022 team, could not join today because of some very difficult personal issues. So I request Dr. Anurag to, who is the president-elect for 2022. So I'll request Dr. Anurag to say a few words and then we start with the proceedings. Thank you so much.
Thank you, Dr. Pankaj. So good afternoon, dear esteemed friends. Greetings from the desk of IAP Delhi. It is a pleasure and privilege to hold our first monthly meeting of the year at Sir Gangaram Hospital, which is a place of academic excellence. And monthly meetings have been a hallmark of IAP Delhi to the extent that third Thursday afternoon is kept free in our department of pediatrics at MAMC as a tradition, so that all can attend the activity. In fact, I remember Dr. Mandal telling me that every third Thursday from Lady Hardinge Hospital, a bus used to go to the venue of monthly meetings. And this was a tradition at that time, and every faculty who was available used to attend these meetings. And I wish that again we bring our monthly meetings to the fore and we are able to restore it to its former glory. So let's bring in some innovative ideas. I understand a lot of traffic is there, traveling has become an issue, but we should bring it to the forefront so that all the senior people can meet at least once a month. It's a good academic activity and a team building exercise. So today, interesting topics are in store for today. One of them is HLH, which a decade ago was hardly a known entity. So I invite Dr. V.K. Khanna, Chairperson, Department of Pediatrics, Sir Gangaram Hospital, and Dr. Devinder Gaba, Senior Consultant Pediatrics and President IAP West Delhi, to chair the session and begin the proceedings. Before that, I hand over the podium to Dr. Pankaj Garg, my close friend, and of course, Secretary IAP Delhi for 2022 to take over from here. Thank you so much.
So thank you, Dr. Anurag. So I will request now Dr. V.K. Khanna and Dr. Devinder Gaba to take the stage. The speaker is going to be Dr. Manas Kalra and moderator is Dr. Anupam Sajde. I request Dr. Khanna and Dr. Gaba to introduce the speaker and moderator and the topic and start the proceeding. Thank you so much.
Thank you, Dr. Pankaj and Dr. Anurag. Good afternoon, everyone. I welcome you all to this meeting on behalf of Sir Gangaram Hospital and the associated other co-hosts, Sir Shri Balaji Action Medical Institute and Maharaja Agrasen Hospital. I wish you all a very prosperous and healthy year to come, which should be free from corona. In fact, this meeting also, Dr. Pankaj would remember that when we were planning to organize this meeting in December, we thought we'll have in-person or physical meeting at Sir Gangaram Hospital. And after the meeting, the academic session, we'll enjoy those garam pakoras and tea. But this Omicron appeared, and then we had to go back to the virtual platform. And I hope in future we'll be able to have this physical or in-person meeting very soon. And coming to today's lecture session, today we have a lecture on a very life-threatening hyperinflammatory disease, which has got very high mortality. And the topic is HLH from basics to conquering the frontier. And the speaker, as Dr. Pankaj has already told, Dr. Manas Kalra. And now I hand over to Dr. Devinder Gaba to continue the proceedings and invite them. Dr. Gaba, please.
Hello. Thank you, Dr. Khanna, and thanks IAP Delhi and Dr. Anurag and Dr. Pankaj. I'm very happy that we have been invited, West Delhi has been invited for the very first meeting of this year. And now I introduce Dr. Anupam Sajde, who will moderate the session. As all of you know, Dr. Anupam Sajde doesn't require any introduction. Everybody knows his achievement very well. And Dr. Anupam Sajde, as you know, is recipient of prestigious BC Roy Award. He has written so many books and has so many awards on his in his kitty. And as you know, he is director consultant at Sir Gangaram Hospital and is chairman of the pediatric division. Dr. Anupam Sajde will moderate the session, and he will introduce Dr. Manas Kalra, who is also a senior consultant in onco-hematology department of Sir Gangaram Hospital. He's a very good clinician and a very nice person, and he works very hard. Dr. Manas Kalra is as a speaker. Now I hand over to Dr. Anupam Sajde for the further proceedings. Dr. Anupam Sajde, please.
Thank you, Dr. Gaba, Dr. Anurag, Dr. Pankaj, and Dr. Khanna for the introducing the topic. Friends, when we were residents, we always had patients who were very sick in the ICU with jaundice, with what we used to call as severe inflammatory response syndrome or multi-organ dysfunction syndrome. And when that would arise, you would say, "Ab to ye nahi bachega," kyunki pata tha ki bhai, they will probably not, we will not be able to save them. Now, over a period of time, over the last 2 decades, we have realized that quite a few of these patients whom we used to discard or we used to feel hopeless about as patients of MODS and SIRS were actually patients of HLH, and which is hemophagocytic lymphohistiocytosis. And we started what I call as marketing the old wine in a new bottle, and that is in the bottle of HLH. Over 1 decade, we have accrued a lot of experience on the management of HLH, and have also been able to save quite a few of the patients. Even those whom we felt would have had 100% mortality, they have been saved. And to talk about these patients and to give our data on HLH, I invite Dr. Manas Kalra. Friends, I have seen the progress of Dr. Manas from the time he joined us and did his fellowship in pediatric hematology oncology, then went abroad to Australia for training in Westmead Children's Hospital, came back, joined us for a stint, and then rejoined us again. It's a pleasure having him with us. And people are very hardworking, but he's hardworking with a smile on his face and is a very pleasing personality. I request Dr. Manas to start his slides and talk about HLH and enlighten us as to how we have been managing our patients of HLH. Dr. Manas, sir.
Thank you, sir. A very good afternoon to IAP Delhi and all its members. And it is indeed a pleasure to be here for the first meeting of 2022, when our hopes are high that we will have a COVID-free era beginning with us. I would like to thank Dr. Deepak Gautam, Dr. Pankaj, Dr. Anurag, and the entire IAP Delhi for giving us this opportunity to share our thoughts on hemophagocytic lymphohistiocytosis. I hope my slides are visible and I am audible as well. So,
everything is fine. Yeah.
Everything is fine. Go ahead.
Thank you, sir. So, the topic that has been given me is HLH from basics to conquering the frontier. And I'll just present the spectrum of disease that we have seen at Sir Gangaram Hospital and our own data, and kind of tell you that, how we have evolved in managing this difficult disease rather successfully over the last 10 to 15 years. So, to give you a clinician's perspective on this disease, I have put across all the cases that we have seen, a spectrum of cases, and I'll take you through them and show you how the management varies from patient to patient, from diagnosis, the underlying diagnosis, to the different, spectrum of etiology that we see this condition being triggered by. So the first case is a 3-month-old baby who was born out of a non-consanguineous marriage and was referred to us from a hospital in North Delhi. The child had fever for 1 month. The birth history was uneventful. The child was dull to look at. There was pallor and there was hepatosplenomegaly. The investigations revealed a hemoglobin of 8, a white cell count of 8,000, and a platelet count of 90,000. There was neutropenia present with 12% neutrophil, but we know that younger children can have a relative neutropenia that is, sometimes just, physiological. The peripheral smear did show some toxic granules. There were reactive lymphocytes and lymphomonocytoid cells. There was transaminitis, SGOT, SGPT was elevated, and the bilirubin was mildly elevated. Not significant for this age. The blood culture, urine culture, malarial antigen was negative, and the fundus for cherry red spot, because in a child with hepatosplenomegaly who's a very young baby, that fundus examination is something which we can very easily do, non-traumatic, and that was negative. As always, most of these children who come to us with cytopenias, look infected, are started on IV antibiotics. We did get a call from the lab that the sample was highly lipemic, and we were wondering why that is. And all these samples, it's kind of difficult to analyze this sample whenever there is too much of lipemia. With the cytopenias and the hematology consult being there, we proceeded with the bone marrow examination. So, this is for the audience. What does the bone marrow picture show? And you all can just look at it and think as to what is going on. But for the sake of time, I'll just move on and say that this is extensive hemophagocytosis, where we can see that, this one monocyte macrophage group of cell is chewing up red cells, platelets, and every white cells. And that is what probably is triggering the whole disease process. There was no evidence of malignancy or evidence of any storage disorder. So in such a situation where you have this baby with organomegaly, and you have hemophagocytosis on the marrow, how do we proceed? So in this particular case, we evaluated the child for the basic HLH parameters, which were ferritin, triglyceride, and fibrinogen. And not to our surprise, the child had very high ferritin. The triglycerides were high, which were responsible for the lipemia, and the fibrinogen was low. Serum interleukin-2 receptor, which is available in Gangaram since 2014, we were the first ones to establish this investigation, was also quite high. The test does take some time for the report to come back. A diagnosis of HLH was made. The child was started on dexamethasone. What is HLH is the question that comes to all of us at this point of time. So HLH is a syndrome and not one particular disease. There are a lot of clinical signs and lab abnormalities that typify HLH, and it is mainly an uncontrolled proliferation and activation of cells of the monocyte macrophage lineage. Life-threatening hyperinflammatory reaction happens in these children, and it leads to multi-system manifestations. When do we suspect HLH? So if you have fever, which is not going away just by the simple treatment or by identification of infection and its management, Splenomegaly is one of the criteria. Cytopenias, again, because HLH mainly involves chewing up of all the marrow precursors, so less hemoglobin. Thrombocytopenia, neutropenia are the typical cytopenias that we see. Hypertriglyceridemia, hypofibrinogenemia, hyperferritinemia, and high soluble CD25, which is the soluble interleukin-2 receptor that I just mentioned. These all are important criteria. If you are able to demonstrate hemophagocytosis, often bone marrow is the site which is easiest to do in these sick children. If you can do that, that really aids into making the final diagnosis. Low or absent NK cell cytotoxicity is the other important criteria. Now, if you satisfy 5 out of 8 criteria, we say that the patient has HLH. Now, why do you see this high serum ferritin in these patients? So serum ferritin is an acute phase reactant, which is mediated by many cytokines. And all these cytokines are released at very high level in these HLH patients. There is increased erythrophagocytosis. And when these cells are breaking down, a lot of tissue injury is happening and the ferritin becomes very high. Ferritin more than 10,000 is highly, highly suggestive of HLH, although the criteria requires only a value of above 500 to satisfy HLH when other parameters are available. Why do you have high triglycerides? That is because when you have activation of macrophages, there is a cytokine storm, which is the main hallmark of this disease. This leads to increased level of TNF-alpha, which leads to further decrease in the lipoprotein lipase levels, and this leads to high triglyceride. Why do you have fibrinogen, which is low? That is because of consumptive coagulopathy, DIC-like situation, decreased fibrinogen production because of macrophage infiltration of the liver, and increased cleavage of fibrinogen from fibrin, which is secondary to increased plasminogen activator, which again is released by activated macrophages. Now, this low fibrinogen can lead to a fall in ESR, like how we see in mass patients of rheumatological conditions. How do we classify HLH? So broadly, we say primary HLH or secondary HLH. Secondary HLH are those where we have a definite identifiable cause, like an infection, a malignancy, or rheumatological condition, which triggers HLH in a child. Primary HLH is generally driven by genetic inborn errors of immunity, which lead to the manifestation of HLH. Now, some people refer them to as familial HLH, where you have many genetic defects that can lead to HLH, and I'll come to that in a bit. Macrophage activation syndrome is a terminology which is frequently used by rheumatologists. When I speak to our rheumatology team, they feel that MAS and HLH are almost similar, in their disease pathogenesis and manifestations. It's just that when you have underlying rheumatological disease, some people prefer to call it as a macrophage activation syndrome. Cytokine release syndrome is another terminology that is used mainly for CAR T therapy or BiTE therapy, which is specifically used for leukemia patients. Why does HLH happen? Why do some children behave in a different way and just undergo this severe cytokine storm problem? So what happens when a virus infects or a tumor cell infects our body? CD8 cytotoxic T cells get activated, and these cells kind of try to destroy the virus infected cell. NK cells also play an important role in doing this process. So cytotoxic T cells and NK cells are important for our normal functioning of immune system. These lead to the release of perforin and granzymes, which lead to breakdown of these infected or bad cells. So you can see that this is a, say a virus infected cell. You can see that there is a cytotoxic T cells, and when they are interacting, talking to each other, and the cytotoxic T cell is trying to kill this cell, it releases these perforins and granzymes, which lead to apoptosis in this patient, and that helps us fight, and that is what forms one of the bases of our immunity. Now, the normal immune system, if we look into detail, goes through many steps. So if you have a trigger, say a virus or something, and this trigger leads to an activation, now in these immune cells, they go through series of events. maturation, polarization, docking, priming, fusion. All these steps happen into these immune cells. Then what happens? An immunological synapse is there. And at that point of synapse, you see all this degranulation happening. And these perforin and granzymes lead to killing of these target cells, removal of antigen, and this leads to termination of immune response, and the body becomes quiet again. So this is a normal immune response. Now, in some patients, this does not happen, and this termination of immune response does not happen, and the immune response stays activated. So the trigger is there is an activation, and there is a failure to kill these target cells, failure to counteract the immune response, and you have an uncontrolled expansion of cytotoxic T cells and a continuous release of cytokines, which leads to clinical picture of HLH. Now, I was talking about the synapse. If the synapse between the virus-infected cell and the cytotoxic T cell remains for a long time, there is continuous overproduction of inflammatory cytokines, and the antigen-presenting cells keep on accumulating. More and more T cells are stimulated, and this leads to the cytokine storm and the immunological catastrophe. Would you like to investigate this patient further to find out the etiology, this little baby who came to us with HLH? Yes. And in this particular case, we looked at torch profile, which was positive for CMV IgM. That led us to do a CMV PCR in the blood, which was 82,000 copies. And we knew that this child has active CMV infection going on. EBV PCR was negative. Immunity profile was done because this child had very high CMV at a low age, but that was all, normal. So in this patient, we made a diagnosis of CMV-triggered HLH, and this patient was managed with ganciclovir followed by oral ganciclovir, and this child improved. Do you want to look for genetic conditions in these patients? So ideally, they say that every HLH child should be evaluated for an underlying genetic disorder, and I'll come to that. In this patient, because of the very young age and a severe HLH manifestation, we did evaluate. We found a heterozygous HLH mutation, not a homozygous mutation, which was reported as uncertain significance. And because there was only this heterozygous and not a homozygous mutation, we decided this child to keep under follow-up. So normally, if you have homozygous mutations, you would go in the chemotherapy transplant way. But in this particular patient, we thought, okay, it has got a CMV-triggered HLH. We managed the CMV. And 2 years post that episode, there is no recurrence of HLH in this child. And if there is further recurrence of HLH, we counseled the family that this child may be considered for a transplant. So no underlying homozygous mutation, and a definite trigger was identified in this particular case. We looked at our patients, that is 118 patients with HLH, and published data from Sir Gangaram Hospital in Indian Pediatrics. These patients were recruited from January 2010 onwards. It was a retrospective study with the median age of 4 years. And all these symptoms, that is fever was the main symptom, hepatosplenomegaly, neurological symptoms, because CNS HLH is also an important manifestation of HLH, and cytopenias were the commonest things that we saw. The median serum ferritin was 6,500. However, we did have patients with ferritin of, say, almost around 3 lakh. The lab used to call us and say, are you sure, doctor, what is going on with this patient? And we said, no, this is HLH. It fits into the clinical description. Primary HLH was identified in 23% of the patients, and the etiologies were infections, rheumatological conditions, and malignancies whenever we talked about secondary HLH. So this was our first case with a little bit of background of what HLH is, what is the pathogenesis behind HLH, and what are the investigations that we do for HLH patients. I'll move on to the next case, which is a 6-week-old girl. She presented with a 10 days history of persistent fever. She was tachycardic, tachypneic, and these were the findings at another hospital in South Delhi from where the patient was referred to us. The child required oxygen by nasal prongs. There was thrombocytopenia to begin with. There were some atypical lymphocytes. Workup for dengue, malaria, torch was negative. There was transaminitis. Cultures were negative. The child was given antibiotics because, I am talking about HLH. So HLH, we know that, every child has HLH. But when this child first presents to you, sepsis is always the first diagnosis, because that is what we see very commonly. And most of the patients end up having some kind of sepsis or dengue or some kind of an infection, and we treat that. And that is what the first reflex for any doctor is. Even in our hospital, that is what probably our first reflex would be. There was worsening distress in this patient and worsening of all the other lab parameters as well, which included liver enzymes, platelets, and coagulopathy set in. The child was not showing improvement. Child got referred to us. And by the time the child came to us, the cytopenias were much worse. Now, evaluation revealed a very high ferritin, that is 90,000, high triglyceride, low fibrinogen, and serum IL-2 receptor also came out to be quite high. So we knew that we were dealing with hemophagocytosis, and the marrow showed that. Now, again, this baby is very young, just a 6-week-old baby, and always immunodeficiencies, malignancies are the things that, come to our mind whenever we see a sick child like this. Florid hemophagocytosis was documented. Further workup did not show a prelim immunodeficiency. The child was given dexamethasone after making sure that there was no leukemia. Supportive care was given, and the child gradually improved. Now, in this particular patient, primary HLH mutation came out to be positive for homozygous for perforin mutation. So this child had a familial hemophagocytic lymphohistiocytosis, which is an autosomal recessive condition. And these patients have to be managed by aggressive chemotherapy followed by a stem cell transplant. And if you do transplant for these patients, the outcomes definitely are much better. So with that plan in mind, we went ahead, gave chemotherapy to this child, and she underwent a haploidentical transplant from her father and is doing very well. So what are the genetic causes? So first one was a secondary HLH, and the second one is a primary HLH. You can have all these mutations in these children, which can lead to hemophagocytic lymphohistiocytosis. Perforin mutations, UNC mutations, syntaxin mutations, and MUNG mutations are the common. They can also be associated with pigmentary disorders like, some forms of albinism like Griscelli-Chiriac-Higashi, where you have this partial albinism in these children, and that kind of helps you to make the diagnosis. So as I said, we have all those steps in the immune system which are required for killing of the virus and killing of the malignant cells or the other abnormalities. And if you have defect in any of these steps, the docking step or the priming step or the fusion step, all these steps, if there are mutations, they lead to some form of a genetic form of a HLH. So the classification can be in this form, where you look at the abnormal genes. You can have these, partial albinism and pigmentary disorders which are triggering HLH. And you can also have EBV-driven HLH, where certain genetic mutations can predispose for a patient not to handle EBV virus properly. And I will not go into the details of this. This is a beautiful paper from India where, they have looked at multiple centers of, the experience of HLH, and it is available free of cost in Frontiers in Immunology. What are the diseases or conditions that lead to secondary HLH? So infections are the most common in India. Dengue, typhoid are the most common, agents which lead to HLH. EBV is another very important reason why a patient can develop HLH. So often these viruses, bacteria, sometimes parasites trigger HLH in a patient, and we need to treat the trigger, and the HLH improves. HLH is associated with a lot of rheumatological conditions. So our rheumatology colleagues are very active in managing what they call MAS in rheumatological conditions. And SLE, SOGIA are some of the triggers for developing HLH. Some of the patients who undergo stem cell transplant develop HLH, and there is a different kind of a pathophysiology in it. I'll move on to the third case, where this patient presented to us with high fevers and pallor. CBC did show anemia, and there were lowish platelets, and the neck nodes were quite big. So, whenever you see such a patient where there is anemia, lowish platelets, higher fevers, this patient was referred to me for this underlying condition with a suspicion of, some kind of a malignancy. The bone marrow, that is our first step, because leukemia is what we suspect. The bone marrow surprisingly showed that there was no leukemia and no infiltrate of any kind of malignancy in the bone marrow. The ferritin was very high, 12,000. So what would be the next step? So definitely their cytopenias are going on and the bone marrow is not showing the disease. So at that time, leukemia is ruled out. We need to evaluate this patient further for why this patient's platelet counts, hemoglobin is dropping. Is it because of excessive consumption, and why the ferritin is going very high? So at that point of time, we took this child for a lymph node biopsy, and the lymph node biopsy showed Hodgkin lymphoma. So this was a case with malignancy triggering the HLH in the patient. And if you treat Hodgkin lymphoma, the HLH will go away. So, although we think that, bone marrow will clinch the diagnosis, and then we have to tell the family, oh no, the bone marrow is kind of normal, or there is mild hemophagocytosis, which somebody could just ignore also. We had to go to step 2 for evaluating and making a final diagnosis. And this child did have a history of, being treated with antibiotics for 3 to 4 weeks and EBV being suspected. And, those were the common DDs, but I'm kind of skipping all that for the sake of time. And finally, we could make a diagnosis of Hodgkin lymphoma triggering the HLH in this condition. So malignancy-associated HLH is an important form of HLH that we see. When we treat the malignancy, the HLH improves. So, macrophage activation syndrome, and, people have been fascinated with differentiating these two conditions. Some say that, when mass happens, then the fibrinogen will be low, whereas in HLH, the ESR will be high. So, there kind of craziness of the immune system being triggered by an underlying disorder, which leads to cytopenias, a high ferritin level, and thrombocytopenia, and low fibrinogen with high triglyceride. I move on to the next case, which is a 7-month-old child who presented with bruises and high fever. He was admitted with lower respiratory tract infection 3 weeks back. Now, this child's platelet were 18,000. Hemoglobin was 8. We live in India and 70% of our community has iron deficiency. So sometimes 8 and 9 is something that we ignore. And we think, okay, maybe it is iron deficiency, we'll give iron. TLC was kind of okay. Neutrophils were present. So because there was severe thrombocytopenia and there was some infection 3 weeks back, doctors suspected that there may be ITP or there can be a leukemia. Marrow was done. Leukemia was ruled out. There was some hemophagocytosis. Often in many, many hospitals, we do not have expert pathologists and they are actually not able to pick hemophagocytosis. So hemophagocytosis is often missed. And they just said, oh, there is no leukemia. Marrow looks okay. So somebody thought, okay, if the marrow looks okay, child has thrombocytopenia, this must be ITP. So the child was given IVIG. Although somebody did do a immunodeficiency workup because there was a history of lower respiratory tract infection. Commonly, ITPs are triggered by upper respiratory minor virus infections, or ITPs just happen without a trigger. The trigger is sometimes unknown. And whatever treatment was given, the child was a little better because there were kind of low IgM. There was a little bit, borderline IgG. And, these were the findings, and IgE was actually elevated. Because the platelets were kind of refractory, this child got referred to us. At that point of time, when we examined this child had a lot of eczema on the skin. The ferritin was 56,000 and DCT was positive, the reason for anemia in this child. So we can see that this child does have some features of autoimmunity. DCT is positive, ferritin is very high. So HLH is going on, which is probably leading to thrombocytopenia. And with the presence of eczema, we thought that maybe this young baby has got some kind of immunodeficiency. And one of the important immunodeficiencies that we see is Viscot-Aldrich syndrome. So this patient's diagnosis was Viscot-Aldrich. We did a simple investigation, mean platelet volume, which is available in all the Coulters. The mean platelet volume was low. The platelets were microplatelets. They were small platelets as opposed to ITP, which generally has giant platelets. And the diagnosis was clinched to be Viscot-Aldrich syndrome, and we could prove that genetically. So please remember, some of the immunodeficiencies also can trigger HLH in our patients. And that is also one reason why you can have very high ferritin in young children, and always rule out immunodeficiency as the underlying cause for HLH, especially in very young babies. I move on to case 5, which is a 3-year-old female child who presented from Patna, Bihar during the peak of COVID Delta virus. So this child presented to the emergency. There was history of fever on and off for 15 days. There was abdominal distension, and there was progressive yellowish discoloration of the body. There was some rashes on the skin, and the child had fast breathing. Now, this child was evaluated outside, as I said, in Patna on day 3 of illness, and received IV antibiotics, but the fever persisted. The child was evaluated at a second center because the child was not getting better. And on day 9 of illness, received IV antibiotics, but the child developed progressive cytopenias. They thought that the child has sepsis, but the child, was referred eventually to Gangaram Hospital after receiving 1 blood transfusion. Now, these are the outside investigations. You can see the COVID peak had just happened in India. And, everybody and anybody, any child who was getting admitted in the hospital was suspected to have MISC. So, look at the counts here. The counts are low, but look at ferritin is high, D-dimer was high, ESR was high. And when you see all these features, and especially, MISC was the leading diagnosis for every patient at that point of time. Rightly so, MISC was kept as one of the differential in this patient. However, cytopenias do appear quite striking. There was history of COVID 7 to 8 weeks back in the family. And that is why, one of the possibilities was MISC in this patient. Now, we did the COVID antibodies, and the COVID antibodies were very high. At that point of time, this was the child with the highest amount of COVID antibodies that we had seen in our hospital. And I know after that, we have seen many, many children with very high COVID antibodies. Cardiac markers were also high. So, again, the suspicion of MISC was strong here. The basic workup for all infections were negative, and the fever was persistent. When we did the bone marrow of this patient with this whole background, we really went down to the hematology lab to discuss, and they said that they could see a lot of hemophagocytosis at that patient. And 2D echo here was kind of normal for this patient. And we were looking at, from the point of view of Kawasaki or the MISC that is usually triggered. Now look at the blood counts in this child, and I'll show you this in the tabular column. And you can see here the ferritin was very, very high by the time the child came as 95,000, and see the degree of cytopenias in this child. So really, really marked cytopenia. The child was requiring a lot of blood transfusion, lot of platelet transfusion, which is typically not seen in other cases of MISC. However, the other markers were definitely positive. So we did manage this child like a proper HLH. Despite just starting on steroids and IVIG, the child was not getting better. The cytopenias were refractory. The child was sick. We had to go in, and after a lot of rounds of discussions with the PICU team, we decided, all of us, that we should go ahead and give etoposide to this child, that is chemotherapeutic agents. Normally for secondary HLH, we kind of withhold these chemotherapies. So say a COVID is triggering HLH or some other kind of virus is triggering HLH, HLH, we usually try to manage them with just steroids and supportive care, sometimes IVIG, sometimes cyclosporin. But chemotherapy and these strong drugs are kind of reserved for cases with primary HLH or refractory HLH who have not responded to the general HLH line of therapy. And this child did demand that because the cytopenias and all the other parameters were just not really budging. The child was sick. So differentiating MISC with HLH can be tricky. With Omicron, I don't know how much MISC we are going to see. But again, when you get flooded with these cases, there are leukemias, there are HLHs, and there are many other conditions which kind of are managed like mist, and we kind of miss the boat because steroids are given in both the conditions, and we are likely to miss these dreadful conditions, and then the children can end up later. And not to our surprise, this child post-COVID with such a severe presentation where COVID triggered HLH or MISC kind of feature was something being thought of, this child also had 2 different mutations, compound heterozygous mutation, and we did identify a primary HLH in this condition also. So all primary HLHs, refractory HLHs will require chemotherapy as per the HLS study, managed best by a pediatric hematology or oncology unit. And this child underwent a transplant, post the COVID peak, and when we could control the HLH, a haploidentical transplant from the mother with the TCR alpha beta depletion, and is doing very well post-transplant. So, when we have looked at our paper, and I mentioned that earlier also, so treatment modalities that were used were steroids only for 42%. So a large population of these HLH can only be managed with steroids or anti-infectious agents to treat their primary disease, and multi-agent chemotherapy and transplants are required for the smaller conditions, smaller number of patients who have primary HLH or who have refractory disease. So far, we have performed transplant for 15 of these patients. It is to be noticed that, if these patients present with severe hyponatremia, hyperbilirubinemia, coagulopathy, or very high serum interleukin-2 receptor, they carry a poor prognosis. And these were the findings from our paper. And we did have high mortality. And believe me, we are getting smarter by the day in picking this disease early and, appropriately managing this condition. So we have many success stories to share of patients who have undergone transplant for difficult HLH, and many more who have been treated for secondary HLH by identifying the correct trigger and managing that appropriately. So I would like to summarize by saying that HLH is an aggressive immunoinflammatory disorder with dire consequences if not recognized early. Prompt diagnosis, good supportive care, and search for an underlying cause are important for having good outcomes. Treating the trigger, chemotherapy, immunomodulation, and transplant for difficult cases are used to manage this condition, and decision is mainly done based on identifying the underlying etiology. Thank you.
Thank you so much, Dr. Manas. We're already little behind the schedule, so if Dr. Anupam can just summarize by 1 or 2 minutes or some comments, and then we can go to the next session. Dr. Anupam, sir.
Thank you, Dr. Pankaj, for inviting me to summarize. What we wanted to share with you is our experience on HLH and how we have collected the data over the last 10 years or so. Also, we wanted to tell you that these patients who have undergone transplant would not have survived if we had not done the transplant in these patients. And we have been able to save nearly 60% to 65% of these patients. And almost all the transplants which we have done in the last 2 years have been a success, including the haploidentical transplants which we have done in HLH. And so over a period of time, we have become better at handling these patients than what we were 10, 12 years back, when transplant in these patients with haplo or with cord, which we did in one of our Pakistani children, was a tough this thing. So most important thing is to be aware of the condition, send the initial investigations, and then manage them accordingly to make sure that we are able to salvage these patients. I think that's all that I have to say. Thank you very much.
Just one thing, one question in the question answer box. Dr. Anupam, where to send the, Dr. Mohit Sethi has asked, where to send the sample for mutation? Can you just tell?
We have been using MedGenome laboratories.
Bangalore, yeah.
Yeah.
That's a good lab, actually. Very good.
Any comment, Dr. Gaba? Then we go to the next session. You are on mute, sir. Dr. Gaba, you're on mute.
Dr. Manas, nice presentation. I think we'll be able to do much better management with this listening to you, and you have done very well. Very nice. Yeah.
So thank you so much, Dr. Manas, Dr. Anupam, Dr. Khanna, and Dr. Gaba for beginning.
Thank you. Thank you very much, Dr. Manas and Dr. Anupam and Dr. Gaba, of course.
So before we go to the second session, Dr. Deepak Gautam, the President IAP, has already joined. So I'll ask him to say a few words and then we can go to the next session.
Thank you, Pankaj, and good afternoon, everybody. First of all, my apologies for not joining in time. And a wonderful CME is in progress, as always, by eminent faculty. So I don't want to be the haddi in kebab. Thank you very much for making this CME a great success, and wishing for the same support in future. And a happy New Year and good health to all. Hope to meet in person in future. Pankaj, please continue with the CME proceedings. Thank you. Thank you.
Thank you, Dr. Deepak, for those encouraging words. Now we come to the case presentation session. And for that, I have the pleasant duty to invite Dr. Neelam Clare, Chairperson, Department of Neonatology at Gangaram Hospital, and Dr. Satish Saluja, Co-Chairperson, Department of Neonatology, Gangaram Hospital. The case which they are going to present is a preterm with complex cardiac surgery. Presenter is Dr. Mudita, and we have moderators Dr. Raja Joshi and Dr. Neeraj Agarwal. So over to Dr. Neelam Clare, please.
Thank you, Dr. Pankaj. I think after an excellent presentation by the Hem-Oncology Department of Sir Gangaram Hospital, by Dr. Manas and able leadership of Dr. Khanna and Dr. Anupam, we are again at Gangaram Hospital, and this time the team is Department of Neonatology and Department of Pediatric Cardiac Services. And as Dr. Pankaj already said, here we have a preterm baby with complex cardiac surgery. So there is a double jeopardy. You know that prematurity itself increases the risk of morbidity and mortality in the survival and the outcomes of a baby. And when this baby has, in addition, a complex cardiac anomaly, then it lands the baby into more pre and post-operative complications. But fortunately, we have a very able, capable, and aggressive pediatric cardiac team under the leadership of Dr. Raja Joshi and Dr. Neeraj Agarwal. So I will not stand in between the presentation, and they are also going to hold back. They're also going to present some of their very interesting data on outcomes of the cardiac anomalies in pediatric patients. But before we hand over to the team who's going to present, I would like to request my co-chair, Dr. Satish Saluja, to add some comments. So over to Dr. Saluja.
Thank you, Dr. Clare, and I would like to thank Dr. Pankaj, Dr. Deepak, and all other office leaders of Delhi IAP for giving us the opportunity to be here this afternoon. And Dr. Neelam has already given the introduction. I would just like to introduce Mudita, Dr. Mudita, who is a senior neonatology fellow in the department and has been working with us for the last 2 years. And she is an excellent worker. I'll request Dr. Mudita to take over and present the case, and then we can have the discussion. Dr. Mudita, please.
Thank you, faculty. Thank you, sir. Am I audible?
Yeah, you are audible, Mudita. Go ahead.
Okay. Good afternoon, everyone, and thank you, IAP, for giving me this platform to present my case here. So today I'm here to present a preterm with a complex cardiac surgery collectively managed by us and along with pediatric cardiac surgery and pediatric cardiology. So we have a 33-week-old preterm baby who was born in Lucknow to a primary gravida mother, born of IVF conception. Mother had history of antenatal hyperthyroidism. Antenatal scans were all normal. Baby was born of LSAS at 33 weeks in view of oligohydramnios. Baby had cried immediately after birth and APGAR scores were around 6 and 7. Birth weight of the baby was 2.1 kg, which was appropriate for gestational age. At birth, baby had respiratory distress, for which baby was shifted to NICU on CPAP and was continued on CPAP for the same. However, in NICU, respiratory distress was noted, and also there were increased FiO2 requirements. FiO2 requirements were pretty high as 70%, and hence baby was intubated and first dose of surfactant was administered, following which baby was kept on SIMV mode of ventilation. On examination, baby was found to have respiratory rate of around 60 per minute, and saturations were seen to progressively reduce from 80 to 90% to 60 to 70% despite high FiO2 requirements. An chest X-ray was done which showed normal to oligemic lung fields. So at this point of time, with this clinical history and a diagnostic suspicion, one of our esteemed faculty, Dr. Pankaj, was telephonically consulted. And the entire clinical history and the diagnostic suspicion, with this, sir made the decision to start the baby on injection alprostadil and injection and to transport the baby to a higher center, that was Sir Gangaram Hospital. This was done to rule out. It was basically a duct-dependent congenital cytopenic disease which was suspected at the back of the mind. Here, I would like to take an expert opinion from Dr. Neeraj, sir, that were we justified start injection alprostadil without having to know the diagnosis? Sir, could you just comment little on this?
Okay, so this patient was in the periphery, and I understand the echo was not available at that stage. Otherwise, here I would have loved to do echo first, but if echo is not available, then I'm talking about a duct-dependent lesion, because whenever I am suspecting a disproportionate desaturation without distress, then I'm talking about a cyanotic heart disease, most common. So the data is there that you can run without echo also relation, and the oxygen requirements are very high compared to the distress. Yeah.
Okay. Dr. Raja Joshi, sir, anything would you like to add?
The data does support that where echo facilities aren't available, the degree of sickness of the child, if you have reasonably ruled out other neonatal reasons for having the clinical presentation. So cardiac reasons are probably very common. The second most common problems that happen, and especially if you have a child who is peacefully cyanosed. I hope I get my meaning clear. They're not very symptomatic as far as respiratory distress is concerned, but they are peacefully cyanosed. This is a child who has possible mixing lesion. And these are the children who, if not treated in time, the hypoxia is going to cause trouble for the body's hypoxic response. So this is what in cardiac terms, it's called ductal shock. Then they're going to get sick. Eventually, everybody will get sick. But initially, while there is a mixing source available, they are peacefully cyanosed.
Thank you, sir. So with this decision, we plan to transport the baby to Sir Gangaram Hospital. Baby was started on IV fluids along with antibiotics and injection alprostadil, and baby was transported on a transport incubator on IMV mode of ventilation at PIP of around 20 with PEEP of 6 and FiO2 requirements of 40%. So what all things should be taken care of when we are transporting a suspected cardiac disease? So first and foremost, that has to be taken care of is to maintain a normal temperature, normothermia, and especially this becomes important in babies like preterm, in which already babies are under the cardiac stress, and we have to reduce the energy requirements that they may be needing. Second, foremost important is ventilation. It is always preferable to intubate the babies before starting the transport, as we know that 3% of the babies, if not electively intubated, may get intubated during the transport. Third, we have to start Prostin, as we've already been told by Dr. Neeraj and Dr. Raja sir. Echo is not mandatory for the same, but when we are starting prostaglandin, we need to anticipate apnea. So it is always preferable that we intubate the baby beforehand. A good IV access is mandatory with IV fluids. It will be very wise if we provide the baby with 2 separate IV accesses. Perfusion has to be taken care of, and if required, inotropes should be started. Normal blood sugars, normal electrolytes should be made sure before starting the travel. We can consider for giving first dose of antibiotics if we are confused regarding cardiogenic versus septic shock. Normal blood gases, central lines, if present, should be secured well. And last but not the least, a high-risk consent should always be taken. So a little bit about injection prostaglandin, which is available as injection alprostadil. It is a prostaglandin E1. We are using injection alpostin, which is the brand name. It comes as a 1 ml ampule in the strength of 500 microgram per ml, the cost of which is approximately rupees 6,000 for 1 ml. The indications for giving injection alprostadil is all ductal dependent congenital heart defects. Echo is definitely not mandatory. During the transport, the baby should be on injection alprost. Doses is 0.01 microgram, which is the lowest minimum possible dose, to 0.1 microgram. If the ductus is restrictive or if the status is unknown, we can start the baby at doses of 0.05 microgram per kg per minute, which we can use. Once the therapeutic response is achieved, we can reduce the rate to the lowest possible dose from 0.1 to 0.05 to 0.025 to 0.01. Looking at the response of the baby. Alprostadil should be administered as a continuous infusion into a large vein. A separate cannula would be a better one. It can also be given through USC. Alprostadil is compatible with 5% dextrose or normal saline. Now, there are generally problems in the preparation. We should dilute the alprostadil to a concentration of 20 microgram or less. While preparation, care should be taken not to allow the undiluted alprostadil to come in contact with the mixing chamber. So it is always better to put an IV fluid first, followed by the injection. And to make a 0.1 microgram per kg per minute, we can make in either 25 ml, 50 ml, 100 ml, or 250 ml. We are usually preferring a 50 ml solution, which gives us the concentration of 10 microgram per ml, and the infusion rate to provide 0.1 microgram per kg per minute will be 0.01 ml per kg per body weight. So for example, if we are to give 0.1 microgram per kg per minute to an infant weighing 2.8 kg, the infusion rate would be 0.01 ml into the weight of the baby, which will give us the infusion in ml per minute. Multiply that by 60, which will give us in ml per hour. So that is 1.68 ml per hour. The adverse effects of alprostadil, as we know, apneas are seen in 10 to 12% of the cases. So a personnel who has expertise in intubating the baby should always accompany the baby during the transport. Another side effects are hypotension, tachycardia, fever, flushing, hypokalemia is seen on long-term use, and increased risk of NEC. We can always withhold the feed of the infant while transport, or if the airway has also not been secured, given the potential that the baby can get intubated if at all apnea occurs. So in NICU, baby was received to us. Baby was euthermic. Baby had heart rate of around 190 per minute. Spontaneous efforts were present. Peripheral pulses were well felt in all 4 limbs. And saturations were 94% on 40% FiO2 requirement. And this was on injection alprostadil. Baby was on SIMV mode with blood pressures were maintained with no upper limb, lower limb discrepancies seen, no obvious dysmorphism, and systemic examination was within normal limits. So we had this preliminary diagnosis of a preterm baby, 33-weeker, was appropriate for gestational age, suspecting a cyanotic congenital heart disease on prostaglandin or with early onset sepsis. So our differentials were transposition of great vessels, pulmonary atresia with ventricular septal defect, tricuspid atresia with PS, critical pulmonary stenosis, and pulmonary atresia with intact ventricular septum. So with this, we continued the baby on SIMV mode at pressures of 15/5. So sepsis screen was sent, antibiotics were upgraded. But however, within first 6 hours of life, baby had gone into shock. We had to start the baby on dopamine and dobutamine, and alprostadil was continued. We had taken cardiology opinion and a 2D echo was done. Right at the admission, which showed transposition of great arteries with intact ventricular septum with a 4 mm AST and a 4 mm PDA with a single coronary artery. However, by 48 hours, shock had worsened. We started the baby on adrenaline. Gradually, over next 48 hours, shock improved, inotropes were stopped, blood cultures were all sterile, and alprostadil was continued on minimum possible doses. So now we know it was a TGA who was a cyanotic congenital heart disease, which we were it was a TGA, but we usually do not expect a TGA to go into shock. Dr. Rajesh Joshi, sir, so could you just tell us that what were the factors which were contributing for the baby to go in shock, since cultures were all sterile and we did not get any markers of sepsis to be positive?
So I think I will be repeating myself. When the duct starts closing, or if you have hypoxia for whichever reason, maybe the ASD is not a good source of mixing, because transposition, as you know, is a mixing lesion, which means that for the survival of the child, you need to have some source of mixing, which is best done at the atrial level. So when the hypoxia starts setting in, the hypoxia takes a toll on the body's aerobic metabolism, and the child starts developing anaerobic respiration. So that's probably the reason this particular child got into the problems of hypoxic ductal shock. And you can see it quite rapidly recovered also. But these are the children, when you have hypoxic shock in that period, they will show some trouble when you are managing them even in the future, because some telltale signs or damages, you have to have your antenna up for diagnosing potential problems in the post-operative period. So it's a history which is very important. Was the child suffering from ductal shock?
Okay, thank you, sir. And further, by day 7, we had tried to extubate the baby twice, 48 hours apart. However, we had failed to intubate. We had failed 2 extubations, and baby had to be reintubated. We started the baby on feeds, which the baby was tolerated well, and repeated cardiology, our pediatric cardiology and cardiac surgeons were in constant touch with the baby, and we were to find the window to operate on. We continued the prematurity care on minimum ventilatory settings of 13/6 with 40% FiO2, and by day 13 we plan to shift the baby to pediatric cardiac surgery for the arterial switch operation. So prenatal diagnosis, and it is very important for a cyanotic heart disease to be diagnosed prenatally, because it improves survival and also allows for a delivery at a tertiary center, and timely postnatal decisions can be taken regarding prostaglandin or balloon atrial septostomy. Delivery should always be taken at a level 3 NICU with a pediatric cardiology expertise available, and if not feasible, then transport arrangements should always be established in advance of the delivery. So baby was operated on 24th December with arterial switch operation with AST closure with PDA ligation. So immediate post-operatively, our team had a few challenges, which they did tackle well. Hemodynamically, post-operatively, baby was continued on inotropic support of milrinone and adrenaline, which was the minimal doses required by the baby. Electively, chest was kept open so as to prevent mechanical tamponade, and it was closed on post-operative day 3. Respiratory, baby was continued on SIMV, weaned gradually to NIV, followed by CPAP, high flow, and then to room air on post-operative day 20. Chest drains were in situ, and baby had high serous drains output, which was managed conservatively by diuretics and albumin. Iatrogenic pneumothorax was developed while removing one of the chest drains, which is a common complication, which was managed by reinsertion of ICD. Baby, in view of prematurity, was also developing multiple episodes of apnea, which was managed by injection caffeine. In renal, baby was on continuous infusions of torsemide, which was gradually tapered, and baby was discharged on oral torsemide and aldactone. Prophylactically, peritoneal drains are inserted intraoperatively. The renal functions, however, of this baby has been normal, and there was no requirement of peritoneal drainage. Central nervous system, baby, pre-operatively, baby was screened by an ultrasound cranium, which was normal, as we always have to rule out grade 3, grade 4 IVH, because these becomes important factors in decision making regarding the surgery of the baby, because baby has to be put on high anticoagulation post-operatively. Baby did require prolonged sedation and had developed opioid withdrawal syndrome, so was managed by clonidine. Baby had developed a transient self-aborting attack of supraventricular tachycardia, for which beta blockers were started. Baby was discharged on them. Baby had developed NEC stage 1, managed conservatively with total parenteral nutrition and antibiotics. Feeds were gradually started from post-operative day 9. And direct feeds were started from day 34. Baby did receive anticoagulation in the form of low molecular weight heparin or enoxaparin, which was transitioned to ecosprin, which was continued as discharge, and a regular ROP and neurosonogram screening was done, which was normal. So our esteemed pediatric cardiology cardiac surgery team has done a total of 236 switch operations, out of which birth weight weighing less than 2.5 kg were 35. Premature babies undergoing arterial switch operations were 14, and out of them only 4 had expired, which was 28%. In all the premature babies, we have operated on as low as 28 weeker and also on many of 35 weekers, and 4 of them were weighing less than 2 kgs. And the mortality, the cause of mortality was intraventricular hemorrhage, acute kidney injury, necrotizing enterocolitis, and a right ventricular infarct. So our baby was maintaining saturation of 94% on room air. Pre-discharge echo showed a PFO with a bidirectional shunt, mild PR with an insignificant PS, no AR, no neo-AR, with a mild AS and a good biventricular function. So baby was discharged successfully on day 37 of life at the weight of 2.5 kg on oral torsemide, aldactone, and ecosprin. Thank you. We can hold the discussion. Over.
So I request Dr. Raja Joshi to please comment on how we could manage this baby and what were the real challenges which was faced.
Thank you, Dr. Pankaj. Dr. Mudita, can you go to the slide where you are showing the first of the 3 outcome slides?
Yes, sir.
That's it. For the sake of audience, I am the surgeon. I really wish to sort of Hello?
Dr. Joshi, we probably lost you. You can say it again.
Yes.
I'm sorry. As a surgeon in the house, I really wish to share certain anguishes that we sort of face and feel every day. If you look at this particular slide very carefully, the outcomes of all arterial switches is a mortality figure of 7.6. Now, this is including any and every type of arterial switch that we have done in the last 10 years in Gangaram Hospital, which include sepsis, which include everything. So 7.6, which is very comparable to what is there in the STS database, the thoracic surgery database from the American Society. This number out there shows a value of 4.8. So we are quite close to that as far as all comers are concerned. Now, if you just shift your focus to children undergoing arterial switch operation less than 2.5 kg, that means low body weight. Just look at that number, which was 7.6% in the overall group, has doubled. It has come to 14. So just merely the fact that you are born underweight has a toll on the outcomes. The third group, look at the first premature group, which is telling you the mortality figures of premature children in undergoing arterial switch operation. That number has gone to almost 30%. So that means prematurity and low birth weight have got a very significant problem as far as the outcomes of switch are concerned. And the last part, you just have a look at the premature babies undergoing closed heart procedures. This is as much as normal as one can get. 6.4% is the mortality figure. But these surgeries are rather simple. PDAs, coarctations, PA bands, things that don't expose the small preterm body to open heart or the heart-lung machine and its complications. So I'm sure a lot of the audience do interact with gynecologists as far as deliveries are concerned and discussions are concerned. If a pre-made diagnosis or fetal diagnosis is available, just for the fear of getting a cardiac patient out soon, we are taking away a good chance if we bring out a smaller baby or a premature baby. And that is what we have our neonatologists constantly talk to the gynecologists, because they interact with the gynecologists more than us. And our gynecologists have started agreeing to the fact that they are waiting. They want to wait a little more in the benefit of better outcomes for surgery. So fetal diagnosis and its planning and better planning, that's where we can we focus on. And Mudita, just 2 slides forward. Yeah, you can see that the causes of those 4 children out of the 14 premature babies is cardiac only in 1. There is a 1.9 kg child who dies on post-op day 16 because of intraventricular hemorrhage. There's the second baby is a 2.1 kilogram child, dies of, in prematurity. Your kidneys are also immature, your lungs are also mature, your intestines are also immature. So these factors do play a role in the outcomes. So you have a renal failure, you have a necrotizing enterocolitis with perforation and an intraventricular hemorrhage. So that is 3 out of 4 die because of non-cardiac reasons. And they are very well documented as causes of mortality for even non-cardiac premature babies. So I think prematurity has its own extra burden over the outcomes of cardiac surgery, open heart cardiac surgery. That's my conclusion of this.
Dr. Raja Joshi, what is the mean age of surgery for premature babies as compared to babies who were born above 2.5 kilos?
Mean age of these surgeries, sir. Let me before I answer your question, I'll try to make a statement. So when a premature baby is born with a condition like this, where open heart surgery is mandatory, maybe I can use the word semi-mandatory. So what we try to do is we try to avoid open heart surgery in the initial phase, maybe 2 weeks or so, try to get him to as near term as possible, which we made a very honest attempt in our baby also. In our baby, we had honestly attempted to feed the child, to grow the child, and attempt to keep the child on Prostin, but make an attempt of extubation. But apnea of prematurity kept us from doing that. So we try to do that. So we try to postpone open heart surgery if possible. Now, coming back to your question, what was the mean age at what we operated was postnatal age would be somewhere around 3 to 14 days. So in premature babies, between 3 to 14 days, because we could not wait any further, because like in this index patient, we could not wait any further because waiting on a ventilator is inviting trouble. So we wait on a ventilator, we'll get into some sort of VAP, and we'll lose the battle otherwise also. So we take a chance and we go ahead and do this.
If the baby is not on a ventilator, what prompts you to do an early surgery rather than allowing them to get up to 36, 37 weeks when their maturity levels are better?
No, that's opposite of what I'm trying to convey, sir. I would not want to expose them to open heart surgery.
No, that's what what prompts an early surgery in babies other than being on a ventilator? Are there certain cardiac features which tell you that, okay, this is the time we need to operate this child?
So early regression, if a patient has good saturation, a very common reason is having a very large interatrial communication. When you have a decompressing lesion which does not allow loading of the heart on the left side, left ventricle, like an ASD, so LV becomes gradually regressive. So LV starts losing its wall thickness. So if we wait too long in a patient who has got a large ASD, he will saturate better for sure, but he will lose his LV's candidacy for a good arterial switch outcome. So waiting beyond 14 to 21 days is, again, in most cities in the world has had a bad outcome. So we would not like to wait beyond 40 days.
Right. Pankaj, can I ask question from Mudita and Neeraj once?
Yeah, sure, sir.
Regarding use of prostin, what is the message for referring centers when they start prostin? Say, for example, in a dose of 0.05, for how long should they wait for the dose to increase to see whether the child is getting stabilized or the child is not responding to prostin or may get worse in a odd case where the prostin may be contraindicated, like obstructed TA-PVC. So what is the message to the referring unit when they start prostin? How do they look for the response and how do they step up the dose before starting the transport? Mudita and then Neeraj can respond to this.
So what we preferably do here is we wait for almost 20 to 30 minutes and see the saturation levels. If the saturation levels are improving, then we say that the baby is responding. But if the saturation levels are not improving, then we try to escalate the dose and then observe further. But Dr. Neeraj can, I think.
So when do you say it is not a duct-dependent lesion after starting prostin?
So, sir, yes, I will add, sir. See, in any case, if the saturation is not reaching above 80%, we have to aim to a sustainable saturation levels. In a cyanotic patient, my aim is to reach saturations above 80%. So if my prostaglandin infusion is not able to maintain saturation above 80%, I would increase the dose. And I will go up to 0.4. 0.4 is the maximum dose where we can go. Suppose the newborn is having saturation of 60% right now. I start a prostin 0.05 something, and the saturation doesn't improve in next 10 minutes. I will go up. I will go up on the dose. I will make it double. So I will make it 0.1. See, I will escalate fast and reduce fast also. Once a ductus is open, saturation should improve rapidly. So I don't think we should wait for half hour. Half hour is too long time. In half hour, probably I will lose the kid. So if the saturation is 80 plus, I'm not starting prostin because I'm waiting for the things to stabilize. 80% saturation in a cyanotic heart disease is comfortable. Child is not going anywhere. So we are okay with this. But if the saturation is 40, 50, I will go with the high dose. Maybe I will start with 0.2 mics per kg per. I go up to 75, 80. I start with the dose. So the target saturations are 80%. That's my doses. So there are different units and different protocols, but different people.
I think your audio is not good, but I think we've got the message.
Start with higher doses like 0.2. Some people start with lower doses and then go up depending on clinical situation of the patient. Yeah, okay.
Okay.
Okay, sir.
So, I think Dr. Neeraj's audio is not probably working.
More thing
can we ask Dr. to conclude?
Hello?
I think
You're not
what-
audible, Neeraj, properly. So can I request Dr. Saluja or Dr. Neelam Clare to conclude this session?
I think I've had enough talk. Let Dr. Neelam Clare take over and conclude the session.
Then I have the pleasant duty of thanking the presenters, Dr. Mudita, and excellent moderation by Dr. Raja Joshi and Dr. Neeraj. As I said right in the beginning, that, you know, when you have a preterm baby complicated by a complex cardiac anomaly, on one side, you have to balance the organ immaturity due to prematurity. So it may take much longer time to stabilize the baby. So there is more chances of putting this baby on ventilator, because this baby may have, in addition, surfactant deficiency, and which would increase the ventilatory need. Not only that, the need for the inotropes is much more in preterm babies because of not only the lung immaturity, but also because they have also more chances of getting into hemodynamic insufficiency. Post-operatively, like, these babies are more prone to go into neck, like our baby also went. Interestingly, I was looking at one series of transposition of great arteries in preterm versus term babies. And though the pre and peri as well as post-operative complications were seen more often in preterm babies, but somehow the time for the surgery, I think this was the question which Dr. Saluja was trying to pose to Dr. Raja Joshi, that, other than need for the ventilator, what else you are looking for when you are doing the surgery? So I guess on one side, you are trying to stabilize the baby, because baby has, in addition, the problems related to prematurity. And at the same time, you don't want to ventilate the baby for a longer time, because you have a risk of ventilatory associated pneumonia, you have risk of chronic lung disease. So I guess you have to balance to operate the baby at a very appropriate time. And I think this is what happened because of an excellent teamwork. And we have an excellent outcome. So thank you very much. And thank you, Dr. Pankaj. Thank you, IAP Delhi, for giving us an opportunity. Thank you very much.
Thank you, Dr. Thank you, Dr. Neelam, Dr. Saluja, Dr. Mudita, Neeraj, and Raja for making this a very interesting session. Now we'll be presenting the second case of this case series, and the other hospital which is presenting today is Department of Pediatrics, Sri Balaji Action Medical Institute. So for this session, we have Dr. R.D. Srivastava, the head of department of Balaji Hospital, and Dr. Richa Parashar, secretary of West Delhi IAP. So I request Dr. R.D. Srivastava to start this proceeding, and Dr. Richa to present tell us about the case. Over to Dr. Srivastava, please.
Thank you very much, Dr. Pankaj and Dr. Gautam, for inviting us for presentation of this case. We are going to present a very interesting and unusual case today. The case is recurrent acute pancreatitis with atypical hemolytic uremic syndrome. This child was admitted with us in our PQ about a year back, a 13-year-old child, a boy, and he presented initially with the problems of acute pancreatitis. But very soon we realized that he has some different problem also, which looked very unusual for him to have with acute pancreatitis, and also quite unrelated. So it was a sort of enigma for us at that point of time, why these two things are happening together. But our team of intensivists and gastroenterologists and nephrologists all came together, and finally we could unravel this case and successfully treated this case. And this child was discharged after about 2 weeks of stay with us, and he went hale and hearty. So this was a very interesting case. So we are presenting this case, and this case is going to be presented by Dr. Chakravarti, who is a DNB final year student with us. And this case will be discussed by Dr. Sneha Kaushik. She is an associate consultant in our department.
After the presentation, I would like to make a brief comment and highlight 2-3 points after the presentation. So over to Dr. Chakravarti for the presentation.
Good afternoon, everyone. I am Dr. Chakravarti, final year DNB resident. I am fortunate enough to present an interesting case in this IAP clinical meet. I would like to thank Dr. R.D. Srivastava sir for providing me this opportunity. The patient is a 13 years old male, presented to our hospital with complaints of upper abdomen pain and vomiting for 2 days, with abdomen pain severe in intensity, more in epigastric region, radiating to the back. Without any history of loose stool, fever, rash, the child has no bleeding manifestation. The child had a past history of admission 1 month prior to this illness for acute pancreatitis with positive COVID antibody. At the time of admission, child was conscious, oriented, well built, with a pulse rate of 93 per minute, normal volume, well palpable with a blood pressure of 140 by 70 millimeter of mercury, above 95th percentile for the age, gender and height. Respiratory rate was 24 per minute, saturation 98% in room air, peripheries were warm with normal temperature. Child looked paler with icterus, no cyanosis, no clubbing, no edema or no generalized lymphadenopathy. JVP was normal. Weight of the child was 70 kg, which falls between 90 and 97th percentile as per IAP charts. And height of the child was 165 centimeter, which falls between 90 and 97th percentile. And BMI was 25.7 kilogram per meter square, which was above the obese percentile. Examination of respiratory system. Chest was bilaterally symmetrical in shape without any mediastinal shift. Bilateral air entry was present and no adductor sound. Examination of cardiovascular system. S1, S2 here normally, no muffling, no murmur. Abdomen examination. Abdomen was soft, not distended. Umbilicus was in central position. Tenderness present in epigastric region. No organomegaly, flanks free, and bowel sounds here normally. Central nervous system examination, child was conscious, oriented, without any focal neurological deficit. We made our working diagnosis as acute recurrent pancreatitis. Child was kept NPO in view of multiple episodes of vomiting and IV line secu. Blood samples were sent for investigation. Child was started on IV fluids and injection ceftriaxone. This is the initial investigations showing hemoglobin of 8.8 gram percentage with raised total leukocyte count of 19,370 cells per millimeter cube, and platelet count was 44,000 cells per millimeter cube. And peripheral smear showed microcytic hypochromic anemia, neutrophilic leukocytosis with toxic granules, thrombocytopenia with giant platelets. CRP was in the higher side, 26.5 milligram per deciliter. Blood urea 96 milligram per deciliter with serum creatinine of 4.6 milligram per deciliter. And we found that total bilirubin was elevated with 2.69 with indirect bilirubin being the predominantly elevated. And serum amylase and serum lipase were grossly elevated in the range of 2,900 and 3,096 respectively. Ultrasound whole abdomen showed liver was enlarged, pancreas was obscured due to bowel gas with mild free fluid. COVID-19 RT-PCR was done as per hospital protocol, which came out to be negative. And serum calcium was in the normal limits, and lipid profile also within normal limits. After 6 hours of admission, child was afebrile with pulse rate of 93 per minute and blood pressure 140 by 80 millimeter of mercury. Urine output was 0.4 ml per kg per hour, and antibiotics upgraded to renal adjusted dose of meropenem in view of severe pancreatitis with sepsis with acute kidney injury, and IV fluids was decreased as per AKA regime. Medical gastroenterologist opinion was obtained, and repeat KFT showed blood urea of 114 milligram per deciliter with serum creatinine of 5 milligram per deciliter, and the creatinine clearance was 25 ml per minute. In view of anemia, thrombocytopenia, indirect hyperbilirubinemia, repeat peripheral smear for hemolysis, serum LDH, reticount, DCT, and indirect Coombs test were sent. COVID antibody came to be reactive with a normal coagulation profile. On day 2 of admission, child was afebrile, conscious, oriented with pulse rate of 104 per minute and blood pressure of 134 by 76 millimeter of mercury. Urine output was still in a lower side, less than 0.1 ml per kg per hour, and kidney function test showed blood urea of 142 milligram per deciliter and serum creatinine of 6 milligram per deciliter, with creatinine clearance being 21 ml per minute. Potassium 5.3 milliequivalents per liter, and LDH was raised around 1296 units per liter, and reti count was normal, and fibrinogen was elevated. Nephrologist opinion was sought, and child underwent 1 cycle of hemodialysis, and 1.5 liters of ultrafiltrate was removed. Child was transfused with 1 unit of packed red cell and 1 unit of single donor platelet during hemodialysis. We have done MRCP, which showed prominent common bile duct, revealing few hypointense filling defects, calculi with edematous and enlarged pancreas in the region of body and tail with mild peripancreatic fluid. And there was a collection of loculated septated collection adjoining the greater curvature of stomach. Child was allowed orally and IV fluids were stopped in view of anemia, thrombocytopenia, indirect hyperbilirubinemia, raised LDH with normal coagulation, workup for thrombotic microangiopathy such as repeat peripheral smear for cystocytes, C3 level, C4 levels, anti-DS DNA, anti-nuclear antibodies, and anti-cardiolipin antibodies were sent. On day 3 of admission, pain abdomen was better and 2 spikes of fever was seen in the child. Pulse rate of 94 per minute and blood pressure of 124 by 70 millimeter of mercury, and second cycle of hemodialysis done. The repeat peripheral smear was suggestive of fragmented RBCs with cystocytes and helmet cells, and direct Coombs test and indirect Coombs test were negative. This is the picture showing cystocytes. Cystocytes are typically irregularly shaped jagged RBCs which have 2 pointed ends. Diagnosis of atypical hemolytic uremic syndrome was made in view of non-immune hemolytic anemia, thrombocytopenia, and acute kidney injury in the absence of diarrhea. Blood culture came to be sterile and C3, C4 levels were normal. D-dimer was on a higher side, and anti-nuclear antibody, anti-DS DNA, anti-cardiolipin antibodies were negative. We had done Adam TS13 level for this child, which was decreased 44%, with the normal reference range being 60.6 to 130.6%. Child underwent plasmapheresis in view of atypical hemolytic syndrome with 3 units of fresh frozen plasma with 100 ml of 20% albumin. 3 cycles, child underwent 3 cycles consecutively from day 3 to day 5 of admission, and the procedure went uneventful. Plasmapheresis was stopped in view of hematological remission, like increase in platelet count and decrease in LDH levels. Child's general condition and urine output gradually improved from less than 0.1 ml per kg per hour to 1.5 ml per kg per hour during the course of treatment. This is a slide showing the hematological and biochemical parameters during the course of the treatment in the child. On day 1, the hemoglobin was 8.8 with TLC elevated and platelet count was 44,000, and blood urea and serum creatinine was elevated and amylase lipase were also elevated. On day 2, the child underwent the first cycle of hemodialysis. With the urine output being less than 0.1 ml per kg per hour. On day 3 of admission, the child underwent second cycle of hemodialysis and the peripheral smear were suggestive of cystocytes. Hence, we had planned for plasmapheresis. So 3 cycles of plasmapheresis were given continuously from day 3 to day 5 of admission. And the plasmapheresis was stopped in view of increase in platelet count of 131,000 and decrease in LDH levels to 360 units per liter. And during discharge, the child had a normal LDH level with platelet count of 5,15,000 and amylase lipase decreased gradually. During follow-up, the child had normal amylase and lipase levels with normal kidney function test. On day 10 of admission, the child was better with a heart rate of 84 per minute and respiratory rate 24 per minute. Blood pressure 110 by 70 millimeter of mercury, saturation 19% in room air, and systemic examination within normal limits, and the child had normal urine output. We made a final diagnosis of acute recurrent pancreatitis with atypical hemolytic uremic syndrome. During follow-up, after 6 weeks, the patient was doing well comparatively and no pain abdomen and no fever. The child had normal urine output and normal blood pressure, and repeat CBC and KFT were within normal limits. This is a summary and timeline of the case. A 13 years old male child presented to us with upper abdomen pain and vomiting for 2 days with no history of loose stool and past history of acute pancreatitis 1 month back. Initial investigation revealed anemia, raised TLC, low platelet count, deranged kidney function test, and raised amylase and lipase with the total bilirubin and LDH level. Urine output was less than 0.4 ml per kg per hour on the first day of admission, and child kept NP1 started on renal adjusted dose of antibiotics with restricted IV fluids as per AKI regime. On day 2, urine output being still lower than 0.1 ml per kg per hour, child underwent first cycle of hemodialysis in view of anemia, raised total and indirect bilirubin, and raised LDH. Workup for thrombotic microangiopathy were sent. On day 3 of admission, the urine output was still on a lower side with 0.1 ml per kg per hour, and second cycle of hemodialysis done. And peripheral smear were suggestive of fragmented RBCs, cystocytes, and helmet cells with raised LDH level, and DCT and ICT were negative. So the diagnosis of atypical hemolytic uremic syndrome was made in view of non-immune hemolytic anemia, thrombocytopenia, acute kidney injury. Child underwent plasmapheresis 3 cycles consecutively on day 3 to day 5 of admission, and the urine output has improved from less than 0.1 ml to 1.5 ml per kg per hour. C3, C4 levels were normal and blood culture was sterile. Antinuclear antibody, APLA anti-DS DNA were negative, with ADAM TS13 levels were decreased 44%. Child became better and discharged on day 12 with final diagnosis of acute recurrent pancreatitis with atypical hemolytic uremic syndrome. Review of literature will be presented by Dr. Snega Kaushik.
Good afternoon, everyone. I would like to extend my sincere thanks to Dr. Aldrich sir and IAP West Delhi for providing this opportunity to present a review in this clinical meet. So firstly, we'll be reviewing the causes of acute recurrent pancreatitis in children. So the most common causes of recurrent pancreatitis in children, one is the obstructive cause. It can be because of biliary stones or congenital malformations of the biliary pancreatic tree or pancreatic divisum. And other common cause of recurrent pancreatitis in children are genetic causes. Cystic fibrosis is one of the causes. So genetic testing for PRSS1, CFTR, cystic fibrosis transmembrane regulator, SPINK1, these are some of the genetic causes which have to be looked for in recurrent pancreatitis in children. And the other causes are systemic diseases, drugs, trauma, and infections. So in our case, biliary lithiasis was the cause for recurrent pancreatitis, as the child presented with the second episode of pancreatitis. Now, coming on to thrombotic microangiopathy, a pathological lesion in which abnormalities in the vessel wall of arterioles and capillaries lead to microvascular thrombosis, they encompass this entity, which is thrombotic microangiopathy. And thrombotic thrombocytopenic purpura and HUS, whether it is typical or atypical, that is Shiga toxin mediated or complement mediated, they come under this category of thrombotic microangiopathy. So our case was hemolytic uremic syndrome. As we all know that hemolytic uremic syndrome is a common cause of community-acquired acute kidney injury in children. And there should be a triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute renal insufficiency. This microangiopathic hemolytic anemia is said when the hemoglobin is less than 10. There are fragmented cells on the PS, that is cystocytes, and there is elevated LDH and decreased levels of haptoglobin. The classification of HUS is broadly classified into infection-induced, which is most common, and earlier it was called as D plus HUS, that is diarrhea-associated HUS, and the most common cause is Shiga toxin-associated HUS. Pneumococcal HUS is one of the causes again. The second classification which comes under HUS is genetic causes. It can be medication-induced like mitomycin C, calcineurin inhibitors, or it can be associated with systemic diseases like SLE, antiphospholipid antibody syndrome, malignancy, and malignant hypertension. Atypical HUS encompasses certain genetic disorders and it can be acquired also. So what encompasses atypical HUS is something which has no diarrhea prodrome. It was earlier known as D-HUS, and the disorders which come under this category are, first is the disorders of complement regulation. This is the most common genetic cause of atypical HUS, and it encompasses the genetic disorders of complement regulation. There can also be acquired disorders of complement regulation, and anti-factor H antibody is very commonly seen as a disorder of complement regulation. Mutation in vitamin B12 metabolism is one more cause, and the third cause, which was there in our case, is von Willebrand proteinase deficiency, that is ADAMTS13 deficiency. Now, this enzyme, if it is severely decreased, if it is less than 10%, it comes under the category of TTP. And if there is partial deficiency of ADAMTS13, that is if the levels are between 10% to 60%, it comes under atypical HUS. So this ADAM13 deficiency can be genetic or it can be acquired because of autoimmune diseases and drug induced. And these genetic forms, they can be either indolent or they are unremitting once they become manifest, or they can have a relapsing pattern precipitated by an infectious illness or a trigger. So what is this ADAMTS13? As we all know, it is von Willebrand factor cleaving protease. So what ADAMTS13 does is it cleaves von Willebrand factor. So if there is deficiency of ADAMTS13, it leads to increase in the levels of von Willebrand factor, and it leads to increase in the platelet adhesion and aggregation and activation to the vascular endothelium, and there is platelet consumption and microvascular thrombosis. It is a zinc-containing metalloprotease enzyme, and if neurological manifestations are more prevalent and the levels are less than 10%, it is TTP, while atypical HUS has more typically severe renal involvement. Now, in the studies, it was also seen that partial ADAMTS13 deficiency may also occur in patients with complement-mediated HUS. And there was a study which was done by Feng et al. And it was published in Blood in 2013. And it was illustrated that several of the 13 patients with the variant in the complement genes also had mild to moderate reduction in the ADAMTS13 deficiency because of polymorphism of ADAMTS13 gene. I'll briefly touch upon the epidemiology and the pathogenesis. This atypical HUS or complement-mediated HUS, it is a very rare disease to have, and the prevalence is 7 per 1 million children in Europe. And this is from the journal which was published in 2010. And most of them are because of gene mutations of the complement factors. And the most common complement factor which is involved here is complement factor H in 20 to 30% of the cases. The pathogenesis, alternate complement pathway is affected in this. And as we know that C5 it is important in the alternate pathway, and it is also important in the pathogenesis. So eculizumab, which is a monoclonal antibody to C5, and it blocks the terminal complement cascade. So it is a line of treatment. This is the first line of treatment in the developed countries for atypical HUS. So what happens is a trigger, that is an infection in a susceptible child who has a genetic deficiency. It leads to uninhibited activation of the alternate pathway, leading to the formation of membrane attack complex and cell lysis. So basically, alternate complement pathway is affected in the pathogenesis of atypical HUS. Now coming on to the management. So international consensus approach to for the management of atypical HUS was published in the Journal of Pediatric Nephrology in 2016. Firstly is the supportive care. We give red blood cells transfusions for anemia when it is indicated, when the hemoglobin is less than 6 gram per deciliter. Platelet transfusion is done if there is bleeding or any invasive procedure is required. Fluid and electrolyte management is done according to the, if AKI is there, we follow the AKI regime. We have to stop all the nephrotoxic drugs or the drugs that can lead to HUS. And dialysis is done in symptomatic azotemia or uremia or severe fluid overload or refractory electrolyte abnormality. As our first PS was not suggestive of schistocytes, so hemodialysis was first done in our case to manage the AKI, and nutrition is looked for. Plasmapheresis, which is the mainstay of therapy in developing countries like ours, is the first line of therapy for the patients during the acute episode of atypical HUS. What plasmapheresis or plasma exchange does is it removes all the defective mutant proteins and antibody to this complement factor H, which is the most common involved complement factor, and it restores the normal functioning complement proteins. It avoids the risk of volume overload and hypertension in patients with AKI. And these plasma exchanges are performed daily until hematological remission occurs. That is, the platelet count improves and the LDH decreases and the schistocytes are no longer in the peripheral blood smear. Eculizumab is available in India, but it is a very costly therapy. And certain indications of eculizumab are when there is no response within 10 days of plasma exchange, or the child has presented with life-threatening complications like seizures, heart failure, coma, or there are serious complications due to plasma exchange, including no vascular access, and there's a confirmed diagnosis of complement genetic defect. These are the indications of eculizumab right now. Otherwise, our first line of therapy in developing nation is plasmapheresis. And plasmapheresis, if instituted early, can be life-saving. Now, in short, I'll be summarizing. When we suspect any HUS, that is if there is a triad of microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury, we have to rule out whether it is typical or it is atypical. If there is diarrhea prodrome, we'll send the stool culture and we'll see whether it is Shiga toxin associated HUS. And if it is D- HUS or atypical HUS, then we have to see whether there is complement protein deficiency or not. So C3, C4, CD46 flow cytometry, anti-factor H antibodies and genetic screening is done in these cases. Although C3, C4 are freely available, anti-factor H antibodies are available in names, and genetic testing in a resource-constrained country like ours is difficult. So accordingly, we call it complement-mediated HUS. And in our case, there was a partial deficiency of ADAM13 TS enzyme also. So to summarize, hemolytic uremic syndrome in the setting of acute pancreatitis is an uncommon association. And this was a case report which we found that acute pancreatitis can trigger thrombotic microangiopathy. So this was a 12-year-old boy who had a blunt trauma, and because of trauma had acute pancreatitis. But 2 days later, it was noticed that the child had hematemesis and hematuria. And on investigations, there was the triad was getting complete, that there were schistocytes, acute kidney injury, and the platelet count was 22,000. So it was found out that it is a thrombotic microangiopathy because of acute pancreatitis. So this case report was published in 2007. And this was a case report which we could found in a child. Otherwise, the data is also very less reported in adults. So another case report that acute pancreatitis is a trigger for thrombotic microangiopathy. This was published in 2021. And this was a 30-year-old male who presented with acalculous acute pancreatitis. And that led to secondary HUS, like in our case. And it was an atypical HUS, and plasmapheresis was done, which was life-saving in this case. And this was a case report that atypical hemolytic uremic syndrome secondary to acute pancreatitis was seen in a 32-year-old male. And early recognition, because we could early recognize this atypical HUS, we could give eculizumab in this case, and patient had full recovery. So eculizumab is something which is given in the developed countries as first line. So the take-home message is that acute pancreatitis may act as a trigger for thrombotic microangiopathy, can cause hemolytic uremic syndrome, and timely initiation of plasmapheresis may decrease the short-term complications and the long-term sequelae. Thank you.
Thank you, Dr. Sneha. I would like to make 2-3 brief comments. As you saw, this child was very difficult patient to manage. The problems were far too many, and it was very difficult to diagnose and treat this case. 2-3 things I want to emphasize. First, that acute pancreatitis can lead to acute kidney injury. This we have seen. Acute severe pancreatitis can lead to acute kidney injury or shock or circulatory failure or ARDS or multi-organ failure. All these things can happen. But all these things are generally attributable to SIRS, Systemic Inflammatory Response Syndrome. And that is what we also thought, that probably this child of acute pancreatitis has acute kidney injury because of SIRS. But the fact that the child had acute kidney injury with thrombocytopenia, and the LDH was very high, and there was predominantly indirect hyperbil, this bothered us. And we thought that there is some ongoing hemolysis. And therefore, on day one, our peripheral smear didn't show any broken RBCs. But again, on day 3, when we sent the peripheral smear for fragmentary, for seeing the helmet cells and all, that came positive. And therefore, our diagnosis of HUS was confirmed. There was thrombocytopenia, there was kidney injury, and there was anemia, there was intravascular hemolysis. So this diagnosis was confirmed. Now we went on to find out the cause of HUS in this case. And we sent all sorts of investigation, as mentioned, but blood culture, complements, DCT. We ran all tests for autoimmune disease, but everything came negative. And therefore, we thought that we must look into genetic mutation now. And when we sent the ADAM TS13 level checkup, that came out to be low, and that was the cause of microthrombi formation and kidney injury. So then this case was labeled as atypical HUS. So my first message is that whenever you're seeing severe case of acute pancreatitis, think of acute kidney injury, not only because of SIRS, but keep this also as a differential, HUS as a differential, especially if acute kidney injury is seen with thrombocytopenia. That's message number 1. Message number 2, as soon as we diagnosed atypical HUS, we immediately started plasmapheresis in this child and gave plasmapheresis for 3 consecutive days, and the child showed remarkable improvement. Now, what is the end point for stopping the plasmapheresis? You must see that kidney functions have returned to normal, LDH has returned to normal, and no longer platelets are being consumed, and their number also comes back to normal. So LDH is normal, platelet is normal, urine output is good, urea creatinine has come down. That is the point when plasmapheresis has to be stopped. So this is the second message, that plasmapheresis in atypical hemolytic uremic syndrome is life-saving. So start early as possible. And third message, that after recovery, these children should not be left alone. They should be followed up continuously for several months or years for any relapse or any development of chronic kidney disease or blood pressure. This child came to us till 6 weeks after discharge, but after that we lost this child in the follow-up. But hopefully, if he has not come, he must be doing fine. So this was the case which was very intriguing, which was very difficult to diagnose and very difficult to manage, but we successfully did it. Thank you.
Thank you, Dr. Srivastava, and I hope that because of the rarity of the case, you will like to present this into some reputed journal, and I'm sure your team is working on that. Before we come to the next case, I just also request Dr. Richa Parashar, Secretary West Delhi IAP, to add a few comments.
Yeah, thank you, Dr. Pankaj. I want to first of all congratulate the team of Sri Balaji Action Medical Institute for a complete workup of this child and for going till as far as detecting ADAM ST13, and for congratulate for complete recovery after the pheresis in such an obese child like this. And I must comment that whenever we clinically suspect a thing, like in this case, the PS was not showing cystocytes, but since there was a strong degree of suspicion when we had raised LDH and predominantly raised serum bill, and Dr. Srivastava sent for a repeat peripheral smear. So I think we should always go by the clinical findings, and if we are thinking of on the lines of something, we must send repeat investigations. Like in this case, we got the cystocytes again. And It was a very good presentation by Dr. Sneha Kaushik and by Dr. Chakravarti, and it was a very comprehensive conclusion was done by Dr. Srivastav sir and very good take-home messages. At the same time, I want to thank the team of IAP Delhi for giving me the opportunity to be on this platform. And also, I want to thank personally President Sir Dr. Deepak Gautam and Dr. Pankaj Garg and our President-elect Dr. Anurag. Thank you, sir.
Thank you, Dr. Richa. Yeah. So now coming to the third case series presentation, and I request Dr. G.S. Kochar, Head of Department of Pediatrics and Neonatology, Regression Hospital, and Dr. Manish Gupta, Central IAP EB member and Senior Consultant Neonatologist at Jaipur Gordon Hospital, to start the proceeding for the third case, which is a complicated enteric fever case. Over to Dr. Kochar and Dr. Manish, please. Mr. Chakravarti, can you stop sharing the presentation?
Hello, everyone. So,
you're audible. Manish, please go ahead.
Okay. Thank you, Dr. Pankaj. Let me start with congratulating the IAP Delhi team 22 with the excellent start with this excellent clinical meet. With already we had 3 very good academic sessions, and this third one, it is going to be enteric fever, the uncommon presentation, basically complicated enteric fever. As our professor used to say, always look for uncommon presentation of common diseases rather than looking for common diseases first, uncommon diseases first. And with my co-chairperson, Dr. G.S. Kochar, we would invite the speaker, Dr. Babita, and moderator, Dr. Piyush. Dr. Kochar, your comments, please, sir. Dr. Kochar, sir?
I think Dr. Kochar is not there. Dr. Manish, you can invite Dr. Babita directly.
Okay. So Dr. Babita, who is a DNB student from Maharaja Agrawal Hospital, is going to present this case with moderator Dr. Piyush Gupta, consultant at Maharaja Agrawal Hospital. Over to Dr. Babita. Dr. Babita, you can start. Dr. Piyush, you want to introduce something about
Good
case
evening,
or
all.
she shall start?
I'm Dr. Babita, DN.
Sir, let Dr. Babita start the case.
Okay. There is echo. Are the 2 instruments logged in the same room? That creates the echo actually.
I'm Dr. Babita, DN. I would like to thank coaches and coach for the golden opportunity. Sir, is my screen audible? Sir? Is my screen visible? Am I audible?
Yes, you are audible. Your screen is visible. You can make it slideshow.
Full screen. Yeah, you can do it full screen, and your voice is little echoing, okay, Dr. Babita.
So this is a case of 13-year-old male, firstborn case of non-consanguineous marriage from Delhi. History was given by mother and reliable. Patient was referred from outside hospital with chief complaints of fever for 7 days, lower limb weakness since 6 days, which later progressed to upper limbs and trunk muscles, and altered behavior since 3 days. Fever was of high grade continuously. Fever got relieved on oral medications. Fever was intermittent, and fever occurred every 6 hourly, even on oral medications. For first 3 days, fever only fever was the chief complaint of the child, but later it was accompanied by abnormal behavior as temperature raised beyond 100 degrees Celsius. Weakness. For 6 days, it was gradual onset, first noticed in lower limbs, later progressed to upper limbs and involving trunk muscles. Patient needed assistance while walking or going to washroom and doing such activities, but patient was able to feed himself and comb his hair. Abnormal behavior. The mother complained that the patient is showing altered behavior in form of altered level of consciousness and complained of visual hallucinations and talking to himself. But there was no history of any rash, any loose stools or constipation, any abdominal pain, any cough, cold, sore throat, any rash, any neck stiffness, any seizure, any breathing or swallowing difficulty, or no history of soiling of clothes, no history of any giddiness. There was no history of any visual disturbance or any facial weakness. There was no history of any recent travel to any endemic area to rule out Japanese encephalitis. There was no history of trauma to spine or any other history of trauma to cranium. There was no history of any abnormal movements or any abnormal sensation or pain sensations. There was no history of any drug intake or any toxin exposure. There was no history of any recent immunization or no history of any weight loss. So there is no such history of similar complaints in the past. There was no such history of diarrhea or no history of respiratory illness in the past 1 month to rule out the prodromal illness.
Okay. I request others to please mute.
There is no history of any past psychiatric issues. There was no past history of any hospitalization. There was no history of any chronic illness or no history of any chronic medication intake. There was no similar complaints in the family or neighborhood. Personal history: patient was there was not on any medications. There was no history of any drug intake. No known allergies. Patient studies in 9th standard and was good in scholastic performance. Appetite was normal. There was no history of any weight loss and normal bowel and bladder habits. Birth and developmental history was normal and patient was immunized till date. So on the basis of history of fever and weakness, my DDs are acute febrile encephalopathy, acute encephalitis, complicated enteric, severe malaria, autoimmune encephalitis, GBS, and ADEM. Treatment history: child was taken to an outside nursing home 3 days back where injection ceftriaxone was started along with supportive treatment in view of positive typhoid IgM. Nerve conduction velocity was done to rule out weakness of the lower limbs, which showed bilateral lower limbs, motor axonal, demyelinating bilateral common peroneal nerve, radiculoneuropathy. CPK was also highly raised. Hence, in view of GBS, patient was referred here for IVIG administration. General physical examination: weight was 30 kg and height was 1.3 meter. BMI was 17.7 centimeter, which falls in underweight criteria. Heart rate was 102 per minute. Respiratory rate on examination was 22 per minute. Saturation was 98% on room air. BP was 106 by 70 millimeter mercury. Peripheral pulses were well felt, normal column, and temperature was axillary temperature 99.9 degrees Fahrenheit. Patient was conscious and oriented to time, place, person. Build was normal. There was no no cyanosis, no clubbing, no pallor, no icterus, no lymphadenopathy, no rashes, no edema. Systemic examination. Respiratory system, chest was bilaterally symmetrical in shape. There was equal rise on inspiration bilaterally. There was no visible paradoxical movements. Air entry was bilaterally equal on auscultation, and there was no adventitious sounds. Cardiovascular system, precordium, apex beat was felt in fifth intercostal space, just medial to mid-clavicular line. There was no thrill, no parasternal heave. S1 and S2 were heard, and there was no additional sounds. Perabdomen, there was no distension, no visible veins, no rashes. There was no tenderness on palpation, no appreciable organomegaly, and bowel sounds were normal. CNS examination, patient was conscious, but there was we observed episodic visual hallucinations in the child. Memory was intact, both short-term and long-term. Episodic slurring of speech was present. It was actually dysarthria, not dysphonia. Cranial nerves, all cranial nerves were intact within normal limit. Motor system tone was decreased in all four limbs. Power was bilaterally 4/5 in lower limbs, both distally as well as proximally, and 3/5 in bilateral upper limbs. There was no involuntary movements present. Sensory system was intact. There was tenderness on palpation of calves, plus pain was present on joint movement. Reflexes were within normal limit, and superficial reflexes were also present. There was no signs of meningeal irritation, and bowel and bladder habits were intact. Stance was normal, but gait was waddling type. Straight leg raising test was normal, and there was no signs of cerebellum injury. On investigating child, we found HP was 13.1 gram per deciliter, TLC was 4200, mild neutrophilic with thrombocytopenic, platelet was 7800, PCV was 39%. LFT, SGOT, and PT was raised. SGOT was highly raised in range of 3511, and SCPT was 416. PTINR was normal. Ammonia was also normal. KFT was normal, but we had dyselectrolytemia in this child. Sodium was 130 milliequivalent per liter. Potassium was normal to rule out hypokalemic paralysis, and ionized calcium and total calcium was also within normal limits. Urine routine microscopy was also within normal limit. Vidal to O somatic antigen and flagellar antigen was reactive for typhoid in range of 1/320. Blood culture was sterile as patient was already having antibiotics from the outside. Thyroid profile was normal, and dengue IgM serology was also negative. To rule out spine and brain involvement, MRI brain and MRI spine was done, which was within normal limits. CPK was highly elevated in the range of 160,000 units per liter. CPK MB was also raised 709 units per liter. LDH was also highly elevated. So to rule out myocarditis, echocardiography was done, which was also within normal limit. First, we suspected this case as a GBS case because of the history of progressive increase in weakness, but their MRI was normal, and due to fever history and DTR was intact. So further on investigation, we found the patient has actually myositis and enteric fever. So it is a case of complicated enteric fever with myositis. Now Piyush sir will explain further. Patient was treated with IV antibiotics, meropenem, which was given for 5 days. Hyponatremia was corrected with 3% normal saline. Steroids was given as it was a case of typhoid with encephalopathy. Injection dexamethasone was used. Supportive therapy and limb physiotherapy was also given. Child improved over the duration of 5 days with improvement in the state of consciousness, remission of fever, and improvement in power of all 4 limbs. CPK was highly reduced over the course of treatment, and child was discharged after 5 days on oral antibiotics. After 10 days on follow-up, there was no history of any speech abnormality, no history of any weakness or delirium or fever. Thank you. Now, Piyush sir will explain.
Dr. Piyush, you like to comment here?
Am I audible, sir?
Yeah,
Yes,
you are audible.
Dr. Piyush.
Yes, sir. The take-home message from this case was, as it was referred from outside, with clear history of GBS, plus patient was having NCV report, which was reported by neurologist as GBS only, but the only thing was reflexes were present, the DTR was present, the child was having highly raised titers in Vidal, 1:640, plus we always suspected why DTRs are present, and CPK was very high, more than 1 lakh, we have seen for the first time. So we discussed in detail with our neurologist. He told, whenever the CPK levels are so high, we cannot interpret the report of NCV. The nerve conduction velocities are not to be interpreted as it is so high CPKs, because myositis is already there, high fever, and because of high fever only, the child was having hallucinations plus such a high titers. Vidal is positive, so it's a clear-cut case of enteric fever. And in enteric fever, everything was explained. Just treat enteric fever, the complicated enteric fever, and you will see without any IVIG or long-term steroids, the child will improve. That's it, sir. Thank you.
Okay, Dr. Piyush and Dr. Babita, that was a very good presentation on complicated enteric fever. Dr. Piyush, after giving like meropenem for 5 days, we discharge on oral antibiotics.
Yes, sir, we discharge on oral antibiotics because the issue was financial constraints and the child was afebrile and improving.
That is, and the steroids were given in the full dose of the 3 milligram per kg dexamethasone and that
Yes,
kind what you give?
Like, sir, like in encephalopathy we give. Same.
So I think that was a timely detection, a good clinical detection of a case who was referred as GBS and later on worked out as complicated enteric fever, and timely diagnosis. And ultimately the good thing is it was diagnosed and patient responded well to treatment. And in the follow-up, patient is doing fine. No residual
no residual weakness,
motor deficit.
Afebrile, no sir, no deficit. The patient came walking in the OPD.
So that was a very good case. Now over to Dr. Pankaj.
So Dr. Kocher is also there. Does he want to comment on anything on this? I could not see Dr. Kocher online. So Dr. Kocher is not there. Dr. Piyush, my question, I know it's going to be a little lengthier session. Why you
Dr.
decided to start
Babita, can you
meropenem?
stop sharing the screen?
Why you decided to start meropenem on this child when the child was on ceftriaxone, which is a very good drug for enteric fever?
Sir, actually in last 3-4 months, what we are seeing, whenever the child with a clear-cut case of enteric, either it is culture positive or in Vidal, on ceftriaxone, already on ceftriaxone, the response is not there. We are giving on day 3 or day 4 after ceftriaxone, meropenem, especially in complications like this, encephalopathy, or in severe, like you can say, deranged LFT, or in myocarditis, any system involvement. And after 3 to 4 days of ceftriaxone, we are changing directly to meropenem. Not in, if the child is stable, we are adding the second line. But if the child is
Is the drug sensitivity? Is the drug sensitivity is also showing resistance to ceftriaxone? Because that's a very
bad trend if it is there?
Sir, actually, the blood culture blood culture in this child came normal because he was already on ceftriaxone for 3 days.
Okay. So thank you so much, Agresan Hospital, Dr. Piyush, Dr. Babita, Dr. Kochar, and Dr. Manish for discussing this very important common case of enteric but an unusual complication of myositis along with hallucinations and starting from GBS, going down to muscle involvement and getting home within 5 days. That's a tremendous hard work which has been done by Dr. Kochar and his team. Thank you so much. And at the end, I'd like to thank all. I understand that once we started the session, there were more than 100 attendees, and now we are reduced to 40. But that is not in hand of organizers. As you understand, in the chat box, I am seeing that some people are complaining of a lengthy session. But that's not what we can do about. We can only request the presenters to be precise within half an hour, but then some things can go out of control. Before we finally finish today's session, I thank everybody, and also that now before we meet the next month for the monthly meeting, there are going to be 2 workshops which is going to happen. One on 10th of February, which is autism or MChat and developmental screening, and then on 17th we have a monthly meeting, and then 24th is another workshop on interpretation of complete blood count. So just keep on looking at your mails. We are trying to send frequent mailers through WhatsApp as well as email so that you get the advantage of all these meetings. With these, I hand over to Dr. Deepak for the final words, and then we can sum up. Dr. Deepak, please.
Thank you, Dr. Pankaj, and thank you everybody for such a nice presentation at CME. And obviously, I request the same help and self-support, same support for the future also. And I think Dr. Khanna wants to say something.
No, I just want to make one suggestion that since there are so many chairpersons, moderators, and so many people.
Audio mute, na?
For that, and like in today's program, if you see there were 12, 13 chairpersons and moderators. Even if they speak for 2 minutes, that becomes half an hour extra for that. So we must keep a margin of their speaking also, and either we keep number of cases less or we give 5 minutes for introduction of the topic.
Very nice suggestion, sir.
This we did in our thalassemia conference, that we kept 5 minutes for changeover and for the to speak. The program goes on time. Otherwise, there is always delay. In all programs, there is a delay. So we don't keep margin for their speaking also in between, and then their comments are, because ultimately after the session we ask for moderators' comments, chairperson's comments. So if they speak for 2 minutes, then it delays the whole thing. That's what I wanted to suggest.
Thank you, sir. Thank you. We'll keep in mind this for the next one.
We can cut down the sessions from 4 to 3. We can discuss that, Dr. Deepak. Yeah. Then thank you all, and have a pleasant weekend, which is just a day after. Keep enjoying yourself. Remain aware that Omicron or Corona is still not away. And I'm sure now as the schools are going to open soon, and we may be seeing a little more pediatric cases with Corona in our OPDs also. So with all these words, again, thanks so much. Bye-bye.
Thank you. Bye. Bye.
Okay, bye.
Good night, everybody.
Okay, bye-bye.
Good night.